Good morning or good evening, depending on where you're at in the world. This is Mark Arnold, Senior Vice President of Marketing with ZAP Surgical. Welcome and thanks to everyone for joining us today for what is our second webinar in the fall webinar series. The fall series does include 11 talks over 11 weeks, and if you haven't done so already, I encourage everyone to go to the fall.srs-webinars.com website to take a look at the talks that we have in store for you. As with all of the series webinars, pre-registration is required to view either the live or the recorded webinars. And one last item of business before we get started. If you'd like to submit any typewritten questions at any point during today's talks, you can do so by using the Q&A button at the bottom of your Zoom console. And time permitting, your questions will be addressed at the end of today's presentation. So without further delay, I'd like to introduce today's moderator, Dr. John Adler. Dr. Adler is the CEO and co-founder of ZAP Surgical, inventor of the CyberKnife, and Professor Emeritus of Neurosurgery and Radiation Oncology at Stanford University. Dr. Adler, over to you.
Thanks, Mark, and I welcome all our listeners to this webinar. I'm delighted to be able to introduce Ian Paddick. Ian hails from London, where he is chief physicist at a number of gamma knife centers there. He's also recently past president of the International Stereotactic Radiosurgical Society. But most importantly, he is kind of one of the brightest lights in the entire radiosurgical physics space. He's been a deep thinker about physics, radiation physics, especially as they relate to radiosurgery. And how many of any of us have formulas named after us, much less the Paddick formula for tumor coverage. So Ian is just a giant as far as I'm concerned in the world we live. And I'm delighted that he could join us this morning, this evening, wherever you are, to talk about his analysis of a range of different medical devices that do radiosurgery today. Ian, welcome aboard.
Thank you very much, John. I'm hoping to be able to share my screen now.
There you are. We can see your slides. Great.
You're good.
Fantastic. Well, John, I don't know if you remember, it was just under 3 years ago that you showed me around the ZAP facility in the Bay Area. And thank you for that. And I must congratulate you for how ZAP's moved forward over that time. So I'd like to talk about platform comparisons in the literature. My disclaimer is I perform ad hoc consultancy work for Elekta. That's what I'm obliged to show you. What I'm not obliged to show you is I work with a gamma knife. And I think if you work with a particular treatment platform, the familiarity with that platform can't help but make you a bit biased towards it. So I'm just showing you that just as a warning. So there have been a lot of treatment planning comparisons over the years. It's not surprising, really. I think if a department is going to upgrade to a new treatment platform, it's a diligent thing to do is to maybe create a few treatment plans as benchmarks, see what the old planning system would do and what the new platform would do. And before you know it, you've got a paper, so why not publish it? I think that's one of the reasons why there have been so many in the literature over the years. First of all, I'd like to take us back a bit and talk about the prerequisites for SRS. Delineation of the target. This is really important. We're not going to cover this today, but it's so important that you can confidently and consistently define what you want to treat. And so imaging is absolutely critical. Conformity. We need to be able to treat the same size and shape of the tumor or target. That's a given. We need to have high dose gradients. So we need to ensure that dose reduces to negligible levels as close as possible to the target. And accuracy. We need to ensure that we're treating what we intend to treat, no more, no less. So what design features do we need for intracranial SRS? Well, we know that a sharp dose fall off comes from the primary beam and how you use it and direct it. We need to have a small focal spot to give us a good penumbra. We need to have low enough energy of the beam, the primary beam, for shorter lateral scatter of Compton electrons. Then we need to have good collimation. So a good penumbra is going to come from collimation that's close to the patient, and we need to have enough to adequately stop the beam where it's not wanted. Now I'm showing you this. This is a brochure for a cobalt teletherapy unit, because I think, just in the same way that I might be a little bit biased towards gamma knife because I'm familiar with it, I think some people are biased against gamma knife because maybe they've never even seen one and they hear that it uses cobalt radiation. Well, one of the things that we're taught in radiation therapy is that cobalt doesn't give you a very good penumbra. And if we look at this brochure, we see that the high activity sources are either 1.5 or 2 centimeters in diameter. Now, clearly that's not going to give you a very good penumbra. That's if you've got a single cobalt source, but we know that the gamma knife uses 192. So actually, if we look at the focal spot of a gamma knife, the individual sources are just 1 millimeter in diameter. If we look at a LINAC, well, actually your focal spot can be as much as 2 millimeters. And furthermore, that can move during treatment. So it's not a given that a LINAC has a smaller focal spot. The other thing we need to make sure is that the energy of the beam is low enough so that you don't get too much Compton scatter outside of the beam. And in this paper, what we're looking at on the x-axis is the beam radius. On the y-axis, we've got ratio of dose to kerma. Now, the ratio of dose to kerma is a little bit like saying it's the proportion of the dose that's not scattered outside the field. And here I've drawn an 8 millimeter diameter target, which I would say is maybe a medium to small size radiosurgery target for intracranial work. And if we look at cobalt 60, so a lower energy beam, we can see that the ratio of dose to kerma is still 1. It then drops off dramatically after then for smaller field diameter. But if we look at, let's say, a 6 MV field, we can see about 20%, there's a 20% loss of dose from the central axis of the field due to the Compton electron scattering outside. Now, we know that the ZAPX has a beam energy of 3.5 MV, so that's actually going to be fairly close to cobalt 60 in terms of the curve there. So this is really important and quite, in a way, counterintuitive. So I'm going to start off in terms of the platform comparison papers with a technical note from Lijun Ma and a host of other contributors in this multi-center study, where they looked at 12 lesions planned with gamma knife perfection, cyberknife, and Nivalis. And you can see in the table that there's a significant difference in the volumes of those lower doses with gamma knife compared with cyberknife and Nivalis treatments. They then followed that up in 2014 with another paper. This was enhanced because they looked at treatment plans generated for 3, 6, 9, and 12 metastases. And again, this was a multi-institutional comparison looking at cyberknife, Nivalis, gamma knife, and the new kid on the block, TrueBeam FFF. When they looked at conformity, it was best for 3 out of 4 gamma knife perfection plans, although for the 3-met case, it was the TrueBeam FFF that got a slightly higher conformity index. If they looked at the volume of normal brain being irradiated per target with the V12, you can see here that gamma knife has a volume just over 1 cc per target, while the other techniques had it started just under 2 centimeters and went up to almost 3 centimeters. But actually, if you look at that, you could say that you're just looking at the difference between a cobalt-based device or a lower energy-based device versus 6 MV devices, where you get a lot more crosstalk between those multiple METs. And so they concluded that for multi-target SRS, it was Gamma Knife that spared the normal tissue brain the best. But we need to critique each of these papers. So let's look at the pros. The pros of that paper were that they used expert planners familiar with their own SRS technology, and that should ensure a fairly unbiased study. They even included 2 TrueBeam FFF centers, and actually those 2 centers came out with quite different plans. The same targets were used for all platforms, so that's good. But the cons were that all lesions were less than 1 cc, and they're all approximately spherical. And we know that that's not always the case in clinical practice. So maybe we need to look at something a little bit more tricky. In exactly the same year, Evan Thomas published a very influential paper where he compared volumetric arc therapy with the rapid arc versus Gamma Knife radiosurgery for multiple cranial METs. And what they looked at there was 28 clinical multi-MET plans. So these were plans that were created in a clinical environment with the Gamma Knife Model C. And then they were replanned with up to 4 arcs with VMAT FFF. In terms of the results, you can see the conformity indices were much, much better with the TrueBeam FFF. So they went from a Paddick Conformity Index of 0.57 for a Model C to 0.83 with a TrueBeam FFF. I must say that the conformity indices for that Gamma Knife were, I would describe them as appalling, very, very poor indeed. Much, much better with the TrueBeam. If we look at the distribution of the indices in this graph, you can see a fairly normal distribution of indices for the Gamma Knife, with no individual MET being greater than 0.8, which really surprises me. In my own practice, we have to give an excuse if the index is less than 0.85, certainly for a single lesion. And yet here, all of them are 0.8 or less. If we look at the distribution of indices for the multi-arc VMAT, you can see that we get a lot of lesions with very, very high index, which approaches 1. This point here that I'm pointing at seems to be an index of about 0.99, which I would say is a little bit suspicious. I know that you can get extremely high indices if you create a very sparse dose grid. You wouldn't want to do that in a clinical setting, but maybe if you wanted to speed up your treatment planning, maybe if you were doing a comparison study, then that's something you might do. So I'm a little bit suspicious of that. I think the main problem with this paper is that they were comparing clinical plans with study plans. And when you create a clinical treatment plan, you aim to do as much good as possible without an excessive drain on resources. While if you're creating a study plan, you aim to get the best parameters possible for that study. They also used new LINAC technology compared with an obsolete Gamma Knife. And it was interesting that 2 years previous to this paper being published, I'd given a presentation on how the Gamma Knife Perfection delivered significantly less dose to normal brain compared with the Model C. So I was very surprised that they didn't think that that was going to be an issue. They also looked at tumors as small as 0.025 cc's. And I would say that volumes that small, it's very, very difficult to get accurate conformity indices or even volumes for these lesions. To give you an example, here's a multi-MET plan that I was involved in planning in a clinical setting. So we've got 4 lesions here. 3 of them are extremely large, and I took every effort to make those as conformal as possible. So the Paddick conformity indices are about 0.9 for these 3 larger lesions. But you can see there's a much smaller lesion here in a non-eloquent location. We know that's going to be safe however you treat it, And so it's got a very, very low conformity index for that one. And that's not a problem in a clinical setting. I might plan it differently if I was doing a study. Still, so they did concede that in increasing numbers of very small targets, gamma knife may retain a small advantage to VMAT with respect to very low isodose spill. And that's quite surprising considering that the gamma knife plans were so poor. In the same year, there was another paper by McDonald comparing the more up-to-date gamma knife perfection with volume modulated arc radiosurgery. And that showed a huge difference in terms of the gradient with the gamma knife versus volumetric arc surgery, with a gradient index of just over 3 for the gamma knife and over 20 for the LINAC, although conformity indices were actually fairly similar. I think the most important conclusion from that paper was they said that the plan quality remains somewhat dependent on the planner's skill with each modality. It also depends on the treatment philosophy as well. How much do you want to cover the target? Do you want to cover with a little bit of a margin? These things are really important. So I would say that metastases maybe aren't the ideal targets for comparing different devices. Conformity and gradient are really important when you're treating benign disease in younger, healthy patients, but it has variable value in older patients with malignant disease and perhaps a poor prognosis. So most of these studies have major flaws, but the literature still points to gamma knife as being a platform that's superior technology for multiple mets. So let's look at benign targets. There are certainly less comparison papers on that. One was this Brussels paper from 2013. So you could certainly say that technology's moved on from then. But you can see here, gamma knife, the gradient index was, in fact, it was the only platform that gave a gradient index of less than 3, with the other 6 MV technologies producing gradient indices of greater than 3. The conformity index was a joint first between gamma knife and Novartis IMRT. But you can see that the volume of 50% of the prescription isodose was significantly higher in those higher beam energy devices. So in 2016, NHS England recommissioned all radiosurgery provision. That required 21 centres to pass a series of QA tests in order to get permission to continue to treat their patients. So this was coordinated by the RTTQA group, that's the Radiotherapy Trials Quality Assurance Group. And they devised tests for contouring to ensure that all centres perform consistent and accurate contouring, treatment planning, so they used 6 benchmarking tests, and also each centre was personally visited for an independent dosimetry audit. So let's look at those 6 benchmarking tests. The very first one is 3 brain mets from a patient with non-small lung cell cancer. 1 brain met was in the brainstem. There were 2 centres that were unable or didn't want to plan the case. And here on the left, if you look at the scatter plot, where we're on the x-axis, we have coverage of the target, and then we have selectivity. Remember, selectivity is the proportion of the prescription isodose that's inside the target. It's the proportion of the prescription isodose that's doing good, if you like. So you want that to be as high as possible. You can see quite a wide range in terms of selectivity, but clearly coverage for almost all of these targets was greater than 95%. If we look at a histogram for gradient indices, you can see the modal average is around 3, but there were some platforms that delivered a much poorer dose fall off outside the target. These were, one centre was a Versa HD, another one was tomotherapy. Now, what about ZAP? ZAP have kindly replanned 3 of these benchmarking cases. And what I've done here is plot the 3 lesions, PTV 1, 2, and 3 for the ZAP plan on top of this, the NHS England study. And you can see that the 3 plans score extremely well, and they're right up at the top with the other best performing plans. Case number 2 was 7 brain mets. You can see in the bottom right a treatment plan with quite a poor bridging dose and a lot of dose spill outside the target, while above that there's a treatment plan with a much better dose gradient outside the target. The RTTQA group devised something called the R50, which I think is a very nice index. It combines selectivity, which is the absence of dose spillage, with gradient. So the R50 is the volume of 50% of your prescription dose divided by the volume of the target. So if you're treating a MET, let's say to 24 gray, then the R50 will be directly proportional to your 12 gray volume, independent of your conformity. So if we look at the results from both of the metastasis cases, you can see a huge scatter plot here of the R50, while on the x-axis we have the PTV volume. And here we've divided the points up into different platforms. So you can see on the bottom here, the green triangles are Gamma knife, the blue diamonds are Cyberknife. We've then got Varian Linac, we've got Electa Linac, and then the orange circles here, tomotherapy. Now you might think that different platforms, there might be a difference in the dose outside the target by what, 10%, 20%, not 30%, surely. Well, here you can see the R50 varies by a factor of 5. So some platforms are able to deliver an R50 of just 3, but some platforms are delivering an R50 of 15 or more. There was a huge difference in the results that we saw from these benchmarking tests. And although it's difficult to demonstrate clearly, maybe you can see that the line here, which represents cobalt-60 energy, is passing through the green triangles, and maybe the 6MV group. It's definitely far more variable, and there are some extremely good 6MV plans in there, extremely good ones. But you can see that there are some poor ones as well. Maybe this is the average that we're seeing for 6MV. And what about ZAP? So we've got the 3 lesions that were planned with a ZAP, and you can see that those come neck and neck with the Gamma knife there. This chart shows you the normal brain V12, where we'd like to get a V12 certainly of less than 30 cc's, I would say. And you can see some outliers here, but you can see these arrows. These represent centers which produced an initial plan, and then following feedback, they were allowed to replan and make their treatment plans better. And you can see that there was a dramatic reduction in the normal brain V12 for following that feedback. Of course, it also depended on what sort of margin you added to your target. And of course, if you add a margin, you are going to spill more into normal brain. So cases 3 to 6 were benign tumors. There was 2 vestibular schwannomas. There was a skull-based meningioma, which the group reported was the most difficult to plan, and a pituitary adenoma. So ZAP have kindly replanned the meningioma and the pituitary adenoma. So I'll share those results with you. If we look at the conformity versus platform, you can see that coverage 93% 97% for gamma knife, 99 for cyberknife, 97 on average for Linac. Selectivity was pretty much neck and neck between gamma knife and cyberknife, with Linac being generally significantly less. If we look at the gradient versus platform, you can see a significant difference, certainly in the gradient index here, with cobalt 60 having a steeper dose fall off than 6MV. And then if we combine the selectivity and the gradient to get the V50, these are the results that I calculated for the 3 different groups. So you can see quite a difference there between the 6MV Linac and the gamma knife there, with cyberknife being somewhere in between the 2. If we look at the R50 versus the target volume, again, you can see a wide range, maybe not as much as for the brain metastases. And here you can see the ZAP results for cases 5 and 6, and you can see that they're right alongside the gamma knife. And I don't think that's particularly surprising. They're both using a very similar energy. They're going to have they should have a steeper dose fall off than a 6MV equivalent treatment. But you can still see there's a huge variation in the 6MV results here. Let's critique all of the trials. So I think the weaknesses of this trial were that treatment time wasn't considered. And while gamma knife treatments typically take much longer to deliver, there's no doubt about that, some of the Linac plans submitted had up to 45 arcs, which perhaps isn't realistically deliverable if the patient's being treated in a mask, certainly. Some centres have since admitted that they couldn't plan the 7 METs case in a clinical setting. But I think this was a really valuable survey of treatments using the radiosurgery platform stock in England at the time. And certainly that's improving all the time as systems are being upgraded. About 75% of the plans were considered acceptable at first submission. That meant that about 25% of centres were asked to resubmit their plans, and they improved their technique with feedback. So this wasn't just about judging centres, it was also about encouraging centres to do better. And I think that was a really good feature of this study. There was one centre that volunteered to cease SRS after seeing that they were an outlier. That was a tomotherapy group. Although not particularly related to this study, 2 centres were awarded super centre status. So they're the only centres now in England that are allowed to treat NHS patients for paediatric SRS, functional targets and AVMs, and they're both gamma knives. And papers describing the study for the multi-centre study for METs and benign tumours both being published. David Eaton was the lead author in both of those papers. And this is just acknowledging the RTTQA team and the expert assessment group as well that took part in this study. There was an ISRS radiosurgery symposium summer of last year, seems like a lifetime ago, where we compared 5 up-to-date treatment delivery devices. And I'm just going to share with you the V12 for these multiple MET treatments here, because I think this is kind of interesting. If you look at the V12, you could almost see that they're from 3 different energy levels, where you've got gamma knife being 6.3 at the lowest, and then you've got element, cyberknife and eclipse all around the 10 cc mark, and then hyperarc being larger. This hyperarc was using a 10 FFF beam, so you can see that the V12 was a bit larger there. Conformity was extremely good in that plan, but in terms of the lower isodoses, more dose spill. But how serious can we really take these studies? You know, what would a dose comparison study look like if we were using the same equipment? Well, I've been lucky enough to visit over 100 SRS centres around the world. And these two treatment plans were performed by different centres using exactly the same platform, a gamma knife perfection. On the left, you can see a vestibular schwannoma treated with just 2 isocenters. The selectivity of that treatment plan was 0.25. I wouldn't even accept that for a multiple MET case. While on the right, you've got an extremely good vestibular schwannoma plan treated just with 7 isocenters, but an excellent selectivity there. Now, if we had these two, if we imagine that these were 2 different platforms and we asked them to plan a series of cases and we compared the 2, we'd certainly say that the platform delivering the plans on the right was a superior platform. But actually, it's just got to do with different treatment planners and maybe different philosophies, planning philosophies that take place in those centers. So to summarize, I think we can say that many platform studies are biased. I fear that the ones that aren't biased will be accused of being biased if they go against the reader's beliefs. But the NHS audit was the largest device comparison study ever made. I think that's a very important study. It does seem as though cobalt 60 and 3.5 MV appears to yield a superior gradient for particularly small targets compared with 6 MV technology. And equipment specifically designed for the job appears to do better, certainly in terms of gradient, the 12 gray volume, etc., and maximizing the dose to the target and minimizing it to normal tissues. So I'd like to thank you very much for your attention. I know I've probably said some controversial things there, so I look forward to hearing your questions and answering them.
Ian, wonderful. I mean, you've been a deep thinker in this space forever, and your analysis, I think, shows it. And there are, as you point out, there are circumstances where every technology can shine, but on average, there are circumstances where it does appear the lower energies work to our advantage with the lowest Compton scattering. So I do have some questions from the audience and a couple for me as well. And I'm just going to go through them, and please tell me what you're thinking. So first is, rightfully says penumbra is a function of source size, collimation, distance, and energy scatter. Does your comparison include cone-based SRS? Now, I think I could answer it, but I'm going to ask you to answer it. Does your comparison include cone-based SRS?
Thank you, John. Cone-based SRS, you're making, you know, there are pros and cons. So the pros are that you tend to get a steeper dose fall off outside cone-based SRS. So you get a very, very good penumbra with cones. The disadvantage, of course, is you can't necessarily shape cones to your treatment target. You know, and that's one disadvantage, if you like, with a gamma knife and even zap-based system, is that we're using cones effectively. And we compensate for that by using multiple isocenters. And that makes the treatment a little bit more complex. It certainly takes longer to deliver as opposed to using micro MLCs. But you do get a steeper dose fall off as a result.
So just the take-home message is cones give you steeper dose gradient, but it's a more complex, longer treatment planning process, which is true for gamma knife, and to some extent true for the ZAP, but we're hoping in time that there's some flexibilities with robots that allow us to make it the penalty very small. So next question, what is the clinical significance of conformity with very small lesions?
Well, that's a fantastic question. We really don't know. If we're talking about small metastases,
yeah.
I think there is probably very little clinical significance. We initiated a prospective randomized trial the Queen Square Radiosurgery Centre, where we randomised metastases between the 4 and the 8mm collimator. The conformity of the treatments was approximately the same, but the dose fall-off was dramatically different. So if we were treating with the 4mm collimator, we might treat to the 50% isodose. With the 8mm, we were treating right up to maybe the 95% isodose. So the dose fall-off wasn't nearly as steep. We didn't see any statistically significant difference between those two groups, although we still haven't accrued the full number of patients that we wanted to with that study. I don't think there is that much clinical significance. I think you can have a MET that's so small it really doesn't matter how you treat it to a certain extent. And we know that in terms of creating radionecrotic lesions, you get below a certain field size and it's extremely difficult to cause radionecrosis. So I think for very small lesions, maybe less impact. I think for benign lesions, it might be very important. So if you're treating a very small vestibular schwannoma right up against the cochlea, then that's where maybe you want the dose fall-off to be as steep as possible.
And I might like to chime in that in the world of functional radiosurgery, where the targets are going to be small, conformity and even probably more so dose gradient is going to be of paramount importance, because we're going to be treating right up to things like the fornix and optic nerves and hypothalamus. So yeah, in the world of brain mets, I agree, there's probably not a big deal for the conformity with small lesions, but I echo your sentiments with benign lesions, especially functional lesions, functional targets. It's going to make a big difference. Okay, another question for you, Ian. Can you comment on the recent Green Journal article by Sebastian et al. That concluded that LINAC-based radiosurgery associated with a lower incidence of radionecrosis compared to the gamma knife for multiple METs? Are you familiar with this article, first of all?
I am. I've written a small review of that article. The title of that article is really quite stunning. But when you drill down in the data, I mean, I think the authors have done a really good job, but you're comparing treatments that have been delivered at two completely different centers. And really the main outcome here is about radionecrosis. And what one center describes as radionecrosis, another center will describe as pseudo-progression. So it's almost impossible to get rid of the bias in that kind of study when you're looking at one center that's delivering entirely with LINAC and the other center is delivering entirely with gamma knife. And then if you look at the grades of radionecrosis, so we know that grade 1 is asymptomatic. And I think in the gamma knife group, 10 times, there were 10 patients, I think, in the gamma knife group with grade 1, while there was only 1 patient in the LINAC group with grade 1. And that skewed the whole data. If you look at symptomatic radiation necrosis, there was actually no statistically significant difference between the two groups. So we have to be very, very careful with these kind of comparison studies.
Okay, I mean, I tend to agree, and I hardly know myself what to make of that study. So here's a question maybe more from me than you. So what is the collimation system for the ZAP? So I urge the listener to go onto the website and you can actually see the collimation system. But the ZAP is basically uses a disc, a rotating disc, a tungsten disc that has conical apertures of various different sizes that can be rotated into position and change beam dimensions from 4 millimeters to 2.5 centimeters, literally in a second. So just go look at it. It's quite novel and it's unlike anything that exists, but it's mostly, think of it as being cone-based more so. It's certainly not your multi-leaf collimation system that most LINACs use. Next question. Congratulations for the presentation. Any comments on the different prescription isodose lines between systems, which does lead to a lot of confusion in this industry. published studies show that lowering the isodose line gradient index is improving. So, Gamma knife often prescribes to the 50% isodose line, and and Linacs more often 80 to 90%. Any comment on that topic? Yeah.
Absolutely, John. That's a fantastic question. I skipped over a slide. I don't know if anybody noticed, but that slide was actually looking at gradient index versus prescription isodose line for the NHS England study. And that was really interesting. And there was a general trend that the lower your prescription isodose line, the better your gradient index. In 2006, when I proposed the gradient index, as part of that technical note, there was a small study looking at the optimal prescription isodose line for the Gamma knife. I was expecting that to be the 50%. That's what I'd always been told. Turns out that the 50% is dogma, nothing more, nothing less. And actually, the steepest dose fall off comes on average with the 40% isodose line when you're using a multiple isocenter treatment technique. And certainly, since I've published on that, there have been multiple CyberKnife and Linac studies all showing that lower isodose prescriptions lead to a steeper dose fall off. So I would encourage centers that use a very high isodose line to investigate using a lower isodose line and look to see what the gradient does. It's crazy, really, that some centers are treating to a high isodose line. So that means giving a lower dose to the center of your target where you've got tumor, you've got hypoxic tissue, which requires a huge dose in order to kill. And instead, you're spilling extra dose out into the normal tissue, which is effectively what you're doing when you prescribe to a high isodose line. So I think there is going to be a trend over the years where we move to lower and lower prescription isodose lines.
No, that's a good point, and I know in my own career I've moved in that direction. Next question is more for me. It says, how does the ZAP system arrive at obtaining Gamma knife-like results while being an MV system? Well, it was really built from the ground up to emulate cobalt, and by designing a MV energy of 3 MV, which gives you an average photon energy of about 1 MV, which is, of course, very cobalt-like. Moreover, the ZapX has kind of maximal solid angle, which is key. And when the more solid angle you can deliver, the steeper your dose gradient ultimately. And then the collimation system is more cone-based Linac, and then the SAD. So by combining a beam energy, solid angle, a more thorough cone-based collimation system, and a shorter SAD, one guts really Gamma knife-like dosimetry, and maybe even some cases even better. So next is considering the question about the clinical relevance of conformity. I believe there is an importance, since we see more and more patients being treated consecutively for a large number of lesions, I guess brain mets. So it's a summation of all treatments that count. So this is more of a, I guess, rhetorical statement echoing the importance of what you've just said, Ian.
Yeah, John, that was actually the other slide that I missed out on during my talk. Was I was showing a patient that was treated with 5 separate radiosurgery sessions for a total of 117, I think, brain metastases over a period of 2.5 years. And when you sum all of those doses together, they can become significant. So yeah, if I can correct my answer when I said that you get to a point where lesions can be so small it really doesn't matter how you treat them. We still need to protect normal brain if at all possible. Certainly if there's no downside to doing that, then we should protect normal brain, because patients do come back for multiple treatments sometimes.
Well, that's a bedrock first principle of neurosurgery: protect the normal brain whenever possible. And so here, another question that is maybe a little removed from where you've been giving your lecture here, but quote unquote, some physicists don't want their systems to use the smallest collimator, the smallest field size, because they prefer a certain dose certainty over geographical precision. For instance, not using the CyberKnife 5mm collimator. What is your view on this? So I guess this has to do with the uncertainty of targeting, the uncertainty of patient position. Do you then defer to using bigger fields? And that kind of defeats the whole purpose of radiosurgery in the first place. But that's, I think, the philosophical question being posed here.
Yeah, I think there are two things here. One, I know that some LINAC groups in the UK don't like to use a field size less than 1 centimeter in diameter. You know, and for somebody using a gamma knife where 2 out of the 3 collimators that we have are all less than 1 centimeter, I find that a little bit strange. But I know that there can be dosimetrical errors or dosimetrical uncertainties when you're calibrating small collimators. I think the nice thing about the gamma knife, and I guess the ZAP as well, is that we're all using exactly the same collimation system. So work done by 1 centimeter certainty. In terms of geographical precision, well, you want to make sure if you're treating, the smaller the target, the more accurate you need to be. So with the gamma knife, we have a frame, and we really like the fact that our patients are not moving at all during functional treatments. I know that's something that's being explored, I think, by ZAP. I think that's probably an essential for functional work and when you're treating these small lesions.
Well, I mean, it is an article of faith that when you're in a frame, you don't move. And I still have not subscribed to that faith. I still believe that there are torques within the frame that are unaccountable for, unmeasurable, and unknowable. And so I think time will tell whether more rigid immobilization, skeletal immobilization, makes for more meaningful outcomes in these small targets. I have one last question, and then we're going to let you go, Ian. And it's a little far removed, but I saw it come up in one of your slides. The super centers of gamma knife centers in the UK, I think, are qualified to treat children. And so I'd like to have you espouse your thoughts about precision radiation with good radiosurgery versus protons, which are often touted as being the preferred modality for children.
Yeah, that's an interesting one. I'm particularly interested actually in the body dose received by patients, because if you're treating a very high dose in the brain, it's surprising actually how much dose is received by the rest of the body. And I think if you're treating very young pediatric patients, we have quite a large pediatric AVM practice at Queen Square. I think it's really important that the body dose is as low as possible for those patients, because it can actually end up being a significant risk to the patients, because these patients are going to live for another 70, 80 years. So that's one issue there. In terms of protons, it's dogma that patients receive less dose with protons. And there have been a number of studies now looking at skull-based tumors, for instance, where actually photons seem to do even better in some cases. If you've got a relatively superficial lesion, then you can take advantage of the Bragg peak with protons and everything's great. But for some lesions, that's not the case. For the proton facilities that are being commissioned in the UK at the moment, as far as I understand, the scanning spot width is 17 millimeters in tissue. It's about 7 millimeters in air, but about 17 millimeters in tissue. So if you imagine what that means, it's a little bit like planning with a gamma knife, but only being able to use the 16 millimeter collimator. You're never going to be able to get a very refined treatment plan with that. So I think I think protons have a long way to go. You certainly need to be able to treat smaller fields with protons to be able to treat a lot of the pediatric indications that we see.
Excellent point. Excellent point. And as you know, Lexell started with protons before he moved on to the gamma knife. So,
Absolutely.
okay. Well, look, Ian, this was just a wonderful lecture. I thank you deeply. I'm sure our audience benefited from what you had to tell, as I know I did. And I thank everyone for participating in this webinar this morning, and wish you well. Okay. Hope to connect soon in person. Okay. Thanks, Ian.
Thank you.
Thank
Bye-bye.
you, Ian.
Goodbye.